Hello, Assalamu alaikum. My name is Dr. Jangir Khan, and I have started the SK Gynae Pink MCQs discussion. This is the fourth paper I am going to solve, and I will go quickly through it. Now, before studying this discussion, do not occupy your mind with wrong answer. Just open your mind so that you don't pick the wrong option during exam. Regarding the cloaca, it gave rise to, now the cloaca is defined as the dilated distal portion of the hindgut. This is the terminal end of the hindgut. It gave rise to anteriorly to urogenital sinus and posteriorly to rectum. Now if you see, there is no right option given. This is maybe a poor recall, but it gave rise to anteriorly urogenital sinus and posteriorly to the anorectal canal. The anorectal canal then gave rise to the anus and the rectum. The urogenital sinus then gave rise to the inferior 2/3 of the vagina and female urethra. But it is the cloaca is associated with allantois. Allantois originate from it. It has communication with the cloaca. So allantois may be the right option, but you have to open your mind. The cloaca gave rise to the urogenital sinus and the rectum. The urogenital sinus then gave rise to the lower 2/3 of vagina and urethra in female, and the allantois has got relation to it. Now there is another MCQ. The superior 1/3 of vagina arises from the superior 1/3 of vagina. The inferior 2/3 arise from here, the urogenital sinus. The superior 1/3 arises from paramesonephric duct. That is the paramesonephric duct. And what causes this division of cloaca into the urogenital sinus and the anorectal canal? That is by mesenchymal proliferation. Mesenchyme. So we do not go into the detail out of the given option. The uterus and the fallopian tube, they arise from paramesonephric duct. Allantois has got association with the cloaca. It is opened into the cloaca. Now the persistent of allantois gave rise to urachus. This is another MCQ. And what is the most common abnormality in the urachus? That is urachal cyst, not fistula. Urachal cyst is on the top. So coming next, baby with jaundice, born 4 weeks. Now remember, after 2 weeks, if there is a jaundice, usually this is obstructive jaundice. And out of given option, biliary atresia. Drugs which can be given in lactation. So that is laxative. Drug which can be given in pregnancy, again laxative. It is safe. Dufalac is the drug of choice for constipation in pregnancy and for constipation in lactation. What is the most common side effect of tetracycline if given to the baby? That is staining of teeth. So option over here is laxative. Amount of oxytocin causing water retention in the kidney, that is 5% or 20 international units. If you give 20 or more than 20 international unit, then it causes what? ADH like effect, and 5%. It has ADH like effect, so it reabsorbs water. If it reabsorbs water, it decreases free water clearance. These are other MCQ. ADH like effect, reabsorb water, decrease free water clearance, and it causes hyponatremia, dilutional hyponatremia. Coming next, breast CA. So in the breast CA, most common quadrant involved in the outer upper quadrant. Another MCQ is it drain to anterior pectoral or anterior axillary lymph nodes. while the medial quadrant drain into which area? that is internal thoracic lymph nodes. So coming next, so already this is discussed, metals that do not allow radiation is the lead, and there is another MCQ on that. In pregnancy you apply the shield on the abdomen. If you are going to do a chest x-ray, that shield has which maximum metal, that is lead. Most common natural source which exposed to amount causes cancer, that is cosmic rays. Cosmic rays causes cancer, it is natural radiation. Muscle cut in episiotomy. Now if you are going to do episiotomy, the muscle that is cut is bulbospongiosis, but the muscle which is at risk of these two are different things. You are cutting the muscle is a normal procedure, but during that procedure there are some other muscle which are at risk of injury. You are not supposed to cut those muscle. So what is the most common muscle that is at risk of injury during episiotomy? That is levator ani muscle. This is another MCQ. True about lignocaine. Now here I am going to explain this MCQ in a very in a little detail because there is confusion regarding this. The actual MCQ is lignocaine toxicity causes what? Lignocaine toxicity causes what? And I will share the reference. So if the question says early toxicity of lignocaine, it causes what? It causes perioral numbness and tinnitus. Perioral numbness and tinnitus, though there are other signs and symptoms and effects, but these are the most common one. So if the question says what are the late effects of lidocaine toxicity? Late, this is seizures. And what is the treatment for early toxicity and late toxicity? For early, answer is observation. For late, answer is lorazepam or diazepam. Whenever there is a seizures. So you must clear your mind regarding this lignocaine toxicity. What is mean by early? What is mean by late? Lignocaine is commonly used as a local anesthetic. So if you give lignocaine and it is stored in this area, and this is slowly absorbed into the blood, so it is early and late manifestation is divided according to not timing, according to the concentration of drug in the blood. This is another MCQ. So early and late is because of the concentration of the drug in the blood, but we will not go into the detail. But right now you have to correct this MCQ. The correct MCQ is like this: early and late. And if there is nothing mentioned like early and late, and the question is there is lidocaine toxicity, what is the most common? Perioral numbness and tinnitus is the most common. If that is not in the option, then the next is seizures. Coming next, false about ischiorectal fossa. The pudendal canal lies in the lateral wall. This is false. Lateral wall. Coming next, which of the following is associated with the maturation reflex? It is self-regenerative. Reference Guyton. Liquefactive necrosis is seen in, this is bacterial infection. Well, there someone has shared the reference. Well, I am giving the reference of a surgery book. There are MCQ, almost 15,000 MCQ in that book. So in that is bacterial infection, that is not pancreatitis. And pancreatitis most common is fat necrosis. Over here the answer is bacterial infection. In brain, hypoxia in brain, which kind of necrosis is there? Coagulative or liquefactive? Answer is liquefactive. Coming next, I will here clear one MCQ. Another, The abscess formation, it is which necrosis? Coagulative or liquefactive? Because there are another MCQ, that is liquefactive. The cavity formation, that is liquefactive. Infection between the lower layer of urogenital diaphragm and perineal membrane will involve, the answer is superficial transverse perineal muscle. Superficial transverse perineal muscle, because they are talking about superficial perineal pouch. We are having two pouches, the superficial perineal pouch and deep perineal pouch, and I will not go into the detail because the candidates are complaining that I am wasting their too much time in discussion, so I have to explain briefly. So we are having a deep perineal pouch and we are having superficial perineal pouch. So you just keep in mind the structure, the superficial perineal pouch and deep perineal pouch and their contents. Over here the right option is superficial transverse perineal muscle. The deep transverse perineal muscle lies in the deep perineal pouch. The deep transverse perineal muscle lies in the deep pouch. So between the lower layer of urogenital diaphragm, so let's suppose this is your urogenital diaphragm, it has got superficial layer, it has got superior layer and inferior layer. So the superior layer of urogenital diaphragm and the inferior layer of urogenital diaphragm, what lies in between? Deep perineal pouch. And between the inferior layer of urogenital diaphragm and the perineal membrane, or the deep layer of superficial fascia, this is superficial perineal pouch. Coming next, structure damaged in the parotid gland surgery, the facial nerve. Facial nerve. And you are going to surgery, you are going to do the surgery of parotid gland. Which nerve is damaged? That is the facial nerve. Coming next, limb drainage of the cervix, both internal and external iliac lymph nodes. Very broad, richly vascularized lamina propria with stratified squamous epithelium. Talking about vagina. Coming next, because fallopian tube has got which epithelium? Columnar, simple columnar ciliated epithelium. Ovary has got which epithelium? Simple cuboidal. Coming next, patient with epicanthal folds, protruded tongue, umbilical hernia. Diagnosis is trisomy 21 and the diagnosis is Down syndrome. Down syndrome. If you remove the epicanthal folds and the patient is having protrude the big tongue and umbilical hernia, diagnosis is hypothyroidism. Hypothyroidism. This is another differential. Epicanthal fold means there are extra folds on this side. Diagnosis of thalassemia, chorionic villus sampling. And regarding amniocentesis and chorionic villus sampling, I discussed with reference to the MCQ given in the previous videos. Labor is initiated by fetal cortisol. Fetal cortisol. Factor having positive impact on positive predictive value is true positive. And factors having positive impact on negative predictive value, that is true negative. Negative predictive value means true negative. Positive predictive value means true positive. True about safe motherhood. Answer is B. It's a component of public health. Focus on the STEM always in exam. They will twist you. True, false, true about safe motherhood except, false about safe motherhood except. So they will twist you. So if ask about false about safe motherhood except, so false and except both multiply. So negative with negative gives positive. So what is the right option then? Thalassemia occurrence in Pakistan ratio, that is 5%. 5%. Coming next. So already explained, this is also 5% in 20 international units. 20%, not 20%, 20 international unit. Old woman with multiple fractures, hypertensive and is on dialysis, reason of fracture. Now the answer over here is the increase in the parathyroid hormone, that is increase in the PTH. And why there is increase in the PTH in the CKD? The reference for this is actually there is a renal osteodystrophy, and the reason for this is I choose the option parathyroid gland. That is because of the USMLE step 3 book, in which they have written that it is actually the parathyroid gland that actually mobilizes the calcium from the bone and causes renal osteodystrophy or the osteoitis fibrosis cystica. So the answer is parathyroid gland. And there are other MCQ, like for example in CKD, what will be the picture? The parathyroid gland goes up, calcium goes down, and the phosphate goes up. Now I will simply explain over here. If you see, if the calcium is down and the phosphate is also down, if both are moving down, think of vitamin D deficiency. Think of vitamin D deficiency. If both are moving up, think about vitamin D excess of vitamin D. Vitamin D overdose. If both are moving in opposite direction, like for example, say calcium is moving down, phosphate is moving up, or you can say calcium is moving up or phosphate is moving down. Now this patient is having problem in the parathyroid hormone. So keep in mind these things. If both are moving up, vitamin D problem. If both are moving up or down, this is the parallel problem. If one is moving up and the other is down, this is the parathyroid hormone problem. And there are other MCQ regarding to this. That is the hypocalcemia, the secondary hyperparathyroidism in CKD. Secondary hyperparathyroidism in CKD, what is the right answer? So in CKD, if there is secondary hyperparathyroidism, so the phosphate level will go. What will happen to the phosphate level? Goes up, because the kidneys are not functioning. The PTH, if it is increased, it actually excretes the phosphate, but only if the kidney function is normal. So the secondary hyperparathyroidism, which causes hypocalcemia, has the characteristic feature of increased phosphate, hyperphosphatemia. Now coming toward the second MCQ. Secondary hyperparathyroidism in case of vitamin D deficiency, what will be the effect on phosphate? Coming toward that, what will be the effect on phosphate? That will goes down, because the PTH, when it is excreted, when it is secreted from the gland, what it causes, it goes into the kidneys, it reabsorbs the calcium, but it pushes the phosphate in the urine. So keep in mind, they will just twist these MCQ. The secondary hyperparathyroidism due to CKD and the secondary hyperparathyroidism due to vitamin D deficiency. Now another MCQ, secondary hyperparathyroidism due to vitamin D deficiency, but vitamin D was replaced, then this will not cause hypophosphatemia, this will cause normophosphatemia, because vitamin D absorbs both calcium and phosphate. So these were the bonus MCQ. Least half-life of GnRH, that is 2 to 4 minutes. Coming next, proprioception sensed by dorsal column. Dorsal column medial lemniscus system. So they can change the MCQ. Proprioception is sensed by medial lemniscus system, not the lateral lemniscus system. Dorsal column medial lemniscus system. Adrenal cortex develops from, it is mesoderm. And which part of the mesoderm? Intermediate mesoderm, because we are having lateral, medial, and we have intermediate. So it is from mesoderm and it is intermediate mesoderm. And the adrenal medulla develops from neural crest cell, that is ectoderm. Neural crest cell, that is ectoderm. Coming next, follicles with the zona pellucida and fluid-filled spaces, this is secondary follicles. The basic difference between the primary and the secondary follicle is these fluid-filled spaces, and these spaces are called antrum. Antrum. So there is another MCQ. There is antrum formation in a follicle. What is this follicle? Primary or secondary? This is secondary follicle. Functional residual capacity already explained in detail in my first video with demonstration. So this is residual volume plus expiratory reserve volume. Residual volume plus expiratory reserve volume, and I have given the bonus MCQs with this in my first video. You can watch from there. So coming next, ureter is not carcinogen, so that is the statement. Prevention of uterine prolapse, that is the cardinal ligament. How many levels are there to prevent uterine prolapse? 3. Level 1, 2 and 3. I will make another video on the uterine prolapse, complete concept, but right now we have to focus on these MCQs. Most important ligament according to the up to date is cardinal ligament. So we are having 3 levels of support. 1, 2 and 3 will discuss in detail. The DPG, that is actually the 2-3 DPG. So that is increased in, now the right answer over here may be missing. That is increased in point number 1, hypoxia. Point number 2, pregnancy. And point number 3, increase in pH, alkalosis. The 2,3 dipeptidyl glycerol, sorry I cannot pronounce it, 2,3 DPG, it is increased in 3 conditions: hypoxia, pregnancy and increase in pH, that is alkalosis. So the DPG is increased in, so you have to look for these options if it is there. If not, then choose the increase in temperature, then choose the increase in temperature. Let's suppose this is your hemoglobin molecule. I am giving you a small concept. This is oxygen and this is that 2,3 DPG. There is competition between the two. If your DPG goes up, it does not allow the oxygen to bind with the hemoglobin molecule, so affinity decreases. So affinity of hemoglobin for oxygen, it goes down. And if the DPG is decreased, so the hemoglobin is free for the oxygen to be connected with it, so the affinity is increased. If the hemoglobin dissociation curve goes toward the left, it means affinity of hemoglobin for oxygen is increasing or decreasing. The answer is increasing. And if affinity of oxygen with hemoglobin is increasing, so there will be increased release of oxygen to the tissue or decreased release of oxygen to the tissue. Answer is decreased release of oxygen to the tissue. If the hemoglobin dissociation curve is moving to the right, it means what? Affinity of hemoglobin for oxygen is decreasing. If the affinity for oxygen is decreasing, so there will be release of oxygen to the tissues. So there is a Bohr phenomena and reverse Bohr phenomena. We will not go into the detail, but right now I am giving you the basic concept. The hemoglobin dissociation curve moves toward the right in case of what? In case of decreased affinity of hemoglobin for oxygen. And what are the causes for that? That is increase in DPG. Second is increase in temperature. The third is the increase in temperature. The third is that moves toward the right, increase in pH. So you have to memorize that table, but the basic idea is to memorize these two things. There is competition between two. So the carboxyhemoglobin and carbaminohemoglobin, what is the difference between the two? Carboxyhemoglobin means carbon monoxide is attached to the hemoglobin, and carbaminohemoglobin means carbon dioxide is attached to the hemoglobin. So do not confuse yourself between the two terms. Carboxyhemoglobin is the carbon monoxide, carbaminohemoglobin is carbon dioxide is attached to it. So the carboxyhemoglobin, the curve will move toward the left. And carbaminohemoglobin, the curve will move toward the right. curve will move toward the right. So I think I am clear regarding this. Well, there is another table, not going to detail, regarding pars distalis. Now the right answer over here is that is supplied by anterior superior hypophyseal arteries. The hypophyseal arteries have two branches, anterior and posterior. So it is anterior superior hypophyseal artery. It is not epiphyseal, hypophyseal arteries. The answer is C. C over here is right. Anterior superior hypophyseal artery. 6-year-old child with a history of sore throat. Now the answer over here is the streptolysin is the right answer. Which of the following is associated with intravascular hemolysis? The intravascular hemolysis. Whenever the RBC is broken down, it gave heme. The heme is carried to the liver. Now who does this function? The heptoglobin. The heptoglobin attaches to the heme. The heptoglobin combines with the hemoglobin. If there is this is RBC and there is hemolysis, so there is hemoglobin is released. So what happens is the heptoglobin carries this hemoglobin to the liver, so the heptoglobin decreases. There is another MCQ that the heme binds with. Heme binds with the hemopexin. Hemopexin, that is another thing. Hemoglobin binds with the heptoglobin. Heptoglobin. Coming toward the next. Discoid race, this is SLE, and the most specific is anti-Smith antibodies. That is missing over here. Anti-Smith antibodies. If that is not in the option, then the answer is anti-double stranded DNA antibody. Anti-DNA, but the first is anti-Smith antibodies. And which titer reflect the disease severity? Answer is double stranded DNA titer. It reflects the disease severity. This is another MCQ. Disease severity, anti-double stranded DNA titers, increasing titer. Which test shows that there is a renal involvement? Anti-Smith antibodies and anti-double stranded DNA antibodies. The answer is anti-double stranded DNA antibodies. Adult polycystic kidney disease is autosomal dominant, and the infant is autosomal recessive. Suspected pre-malignant lesion of cervix, most cheap test to be done is pap smear, and pap smear is the screening test. Colon carcinoma first metastasized to lymph node. There is another MCQ that asks colon carcinoma first metastasized to which organ? First is, if organ is not mentioned, then it is lymph node. But if organ is mentioned, lymph node is not an organ, then that is liver. Another MCQ is that colon carcinoma metastasized to the lymph node. After lymph node, it will metastasize to which organ? Answer is liver. Coming next. So there is another MCQ that is coming to my mind. Renal carcinoma metastasized to the liver through inferior vena cava. The renal vein, it drains into the inferior vena cava, and from the inferior vena cava it metastasizes to the other organs. Prostate metastasizes to the vertebral column through venous plexus. Disorderly reversible growth with increased nuclear ratio is dysplasia. That is dysplasia. The reference for this MCQ is EMBOS, USMLE, step 2. Hormone given in metastatic tumor of breast apoptosis, already discussed. That is the programmed cell death. And the unprogrammed cell death is necrosis. Which one will cause inflammation? The answer is necrosis, because this is unprogrammed. this will cause inflammation. Least teratogenic drug is SSRIs. These are the least teratogenic drug.